Hi everyone. Thank you for joining us for this is Advanced Critical Care Echo teaching for the week. I'm sorry I haven't been here for a few weeks. We've had obviously a big time with DDU exams and the rest going on, and thanks to Emma, who's here on my right, for sort of organising things for the last few weeks. And so it's nice to be back. We're going to just go through a bunch of cases if you guys are up for that. These are just, I guess, a collection of cases that we've had from, you know, a few years ago that a friend sort of brought up to ones that have been sort of around from the last month or two around through the Echo Lab. And so we'll start simply and we'll work our way up. Can you guys first of all see the screen? Is it coming up okay on the other side? Give me a thumbs up.
Yeah.
All right. So we've got a lady here who is, I think she was something like 70 years old or so, and she's presented to hospital with an query ST elevation MI. And I guess I didn't see the ECG, but I know that there was some debate about whether this was a true ST elevation or not. And so this lady did not go directly to the cath lab. The ED felt it was an ST elevation MI. The cardiologist disagreed and started talking about sort of abnormal takeoff. There were certainly ST segments that were abnormal, and she had troponins in the 4,500s. And hence we were called to come along and do an echo for this lady. She was short of breath. This was sudden onset of shortness of breath with these acute ECG changes. And we'll just go through the study. So this was performed in the ED an hour or two after presentation to the emergency department. I'm not going to pick too much. Is that right? Yeah. Ben, let's start with Ben. All right. So, how do you want me to do this? Are you happy with the 6 and 1?
Yeah,
this is 4. Is it 4?
No, I think
Let's do 4. It might be better the other end.
Sure. So, I've got a series of parasternal long axis views with zoom in the bottom right, color Doppler over the bottom left. The things that the 2 findings that bother me the most in this series of images are one, that there is normal to hyperkinetic contractile function in the basal segments of the anteroseptal and prolateral wall, with in the mid segments of the same walls probably hypokinetic. Given that there's normal to hyperkinetic contractile function basally, I'm worried that there's going to be some left ventricular outflow tract obstruction. From what you've told me, I'm thinking it's just going to be a tachypsubos to start with. It can be ST elevation, myocardial infarction force. Doesn't quite look like a myocarditis. From what I can see, but there'll be another possibility given the troponins.
Same as Niall. I'm just seeing the home screen.
Oh, so what screen are you seeing?
Just with the job listed, not with the images. I don't think Niall or neither of us can see the images.
Oh, sorry, I thought you said you did. That's my bad. Excuse me.
Yeah, we did before you. You clicked on them maybe, but it hasn't come up on the other screen.
Oh, that bad boy. How does that look now?
Perfect.
Sorry about that. So, so 70-year-old lady, super high, abnormal ECG, query ischemia, and regional wall, and troponins in the 4,500.
Yeah. I mean, additionally, there's a lot of B lines coming off that posterior region, suggesting a component of acute cardiac impairment or interstitial water. Regarding the rest of the study, like the left atrium is like probably of normal size. Right ventricular outflow tract is probably of normal size. The aorta looks okay. Aortic valve looks okay.
Nice. What were you saying about the? You thought that there was some form of. I'm going to decrease this down for everyone else.
Sure.
So, what were you talking about the movement? Talk to me about the movement of the mitral valve in there.
Yeah, sure. Yeah. So the opening and closing of the cusps, that appears unrestricted, and during systole, when the aortic valve's open, mitral valve's closed, there looks to be of having dynamic left ventricular outflow tract obstruction due to having some anterior motion of the mitral valve, the anterior mitral valve.
Yeah, very nice. So this is arguably the best pathology in the world, which is SAM. So this is systolic anterior motion of the anterior mitral valve leaflet, right? And so we've got these, you've got this massive regional wall motion abnormalities, and just for the guys who are maybe just starting out doing some of this stuff. So maybe we'll just stick first of all with the regional wall motion abnormalities. So what walls are we looking at here?
So I'm looking at the anteroseptal and infralateral.
Yeah, anteroseptal and infralateral walls, beautiful. And then we've got the basal segments that we can see here and the mid segments that we can see there. And if we just compare, so the guys are just starting out, we've got that 16 or 17 segment model to the heart, and we've got to go through each segment in turn. And you get a couple of different bites at the cherry when you're analyzing the echo. But we'll start here with the, as Ben was saying, the anteroseptal and infralateral walls. And so we've got the basal segment. We're going to compare it from the base there to the mid. And the mid one you can see is not thickening even close to as much as that one. And I'd say that is thickening normally, and that is not thickening at all. What's normal thickening?
Greater than 40%.
Yeah, and well, I say 50, yeah, fair enough. And what's hypokinetic?
Between 40 and 20, the numbers are less than 20 or 15.
Yeah, 15 or 10, yeah. And that one is clearly, I think, they're not moving that. So we've got akinetic mid segments and normal thickening to the basal segments, okay? The next thing to look at, and I'll just put it back up to full speed. The next thing that Ben's absolutely picked up beautifully is worried that if you've got hypokinetic basal segments secondary to the sort of the mid and the apical segments, is to worry about whether you're going to get some form of LVOT obstruction. So here we've got a really nice example of the anterior mitral valve leaflet being pulled into the LVOT during systole. And you get better with practice looking at it. And the only way that the tip and the trick I have is if you look at where I put my cursor there, if you look at that point in the left ventricle chamber, and then you use your peripheral vision to look into the LVOT. So don't look directly at the LVOT, but you're looking in here to try and get an idea of when the valve is squeezing. When the ventricle is squeezing. And when the ventricle is squeezing, that's systole, right? So if I know when the ventricle's squeezing, I then use the peripheral vision to see if the valve comes into the LVOT during that section. And now I'm going to slow it down. It's always easier looking at it in slow form. So squeezing and pulling in, squeezing and putting in. Yep.
It's almost maybe like some caudal sound, isn't it? Rather than the full mitral leaflet going.
Yeah.
So really interesting comment there about whether we're looking at caudal or whether we actually caudal sound, so as in just a few cords being pulled in, or whether we're looking at the whole valve, and that's what the real crux of it is in. So how are we going to tell if it's caudal sound versus actually the whole valve being pulled into the LVOT?
Well, I think we need more views, and then we could use a modality that's good temporal resolution as well. So M mode is nice to put through. It might help delineate the structures a bit better. And then look at it in more views.
And I was also going to say that continuous wave Doppler is going to tell us, because if you imagine that you've got a whole of LVOT, if it's just a cord being pulled into it, you're not going to get massive amounts of obstruction, as opposed to if you've got a whole valve being pulled into it, that's where you start to get the obstruction. I sort of sometimes help try and differentiate it like that. Of course, you can get gradients with cords, but I guess whether it's clinically significant or not is, for me, the big question. So what's the, let's move on to.
That's nice.
Wicked, look at these. I wonder how I can do.
Yeah.
I want to put, here we got, so which part of the heart is this? You guys are starting to learn echo, right? What's this view, and what are we looking at?
The
Short axis. So short axis, where we're looking at the, I imagine cutting the heart across the front. And here we've got the mitral valve in here with the bigger anterior mitral valve leaflet, and there's the posterior mitral valve leaflet in there as well.
And you're just cutting across in from here.
Yeah,
down.
so cutting across the heart there. So in short axis. Here's the mid-papillary level, where we've still got pretty good function going on, but we can see the papillary muscles in there, the anterolateral and the posterior medial. And then we start to come up, and it's absolutely akinetic, right? So what's the, and then we come up to the apex just in there. So it's akinetic, sort of, mid and apical sections. So what's your diagnosis? What's causing all this?
So my two differentials here are coronary artery disease of the left anterior descending, or Takotsubo's. Now looking at that looks lovely. They'd be the two differentials I'm worried about, and then the implications of those. So coronary artery disease, you need CAT to prove potentially address it with stenting or whatever. And then Takotsubo's, and also with coronary disease, I'm worried about the fact that there's potentially dynamic ventricular outflow tract obstruction here. I can't recall what her blood pressure was at the start. Assuming it's normal, but I would be worried about reduced cardiac output. I'd also be worried that, given what I see, someone's going to come along and if she is hypotensive, whack her on a whole bunch of fast, strong, heart-beating druggies,
nice.
and then she gets all the drugs and she gets all the dead.
Yeah, beautiful. So just you said, like, the Takotsubo is what this looks like. I think it absolutely could be, but it's a diagnosis of exclusion. You've got to exclude coronary artery disease, because the other thing that can look like this is obviously LAD territory infarction. So you've got to exclude LAD territory infarction, and that's why obviously this lady needs to go for an urgent cath, because I think the two treatments are obviously slightly different. And let's just focus in a bit on this. So the next part we're going to want to do, if we think that we've got systolic anterior motion of that valve, and I'll pause it actually. So during systole, so systole is from the beginning of the QRS to the end of the T wave. So during systole, we can see here, so during systole, I can see that anterior mitral valve leaflet is not where it should be, and it's there sitting in the LVOT. So it's going to be causing some form of obstruction. Okay. Systole into the valve. And interesting, just remember that the mechanism for that is either a Venturi effect, which means that the blood flowing into the LVOT, it's narrowed because of the hyperdynamic function, which means that you create a sort of turbulence and it sucks in the blood. That's probably got something to do with it, but particularly in areas like Hokum, they actually think that more of it's to do from a pushing effect when you've got the apically displaced. This lady doesn't have Hokum, but if you did have Hokum, it was these apically displaced papillary muscles kind of pushed the valve in. There's probably a bit of both going on in these. We don't really know enough about it, I think, but so it's basically a Venturi as well as a pushing effect. Let me look if there's. It's freezing. I just want to see if I can show you some M mode, because I want to see if we've got any MR. We don't really have. All right, before I get there, okay, does someone want to tell me what we are imaging here and what 1, 2, and 3 indicate? I think it's one of the useful things. Yes, it kind of gives it away on the labeling, because the sonographer's done too good a job. If
there's no takers, then we're looking at pulse wave in a pulmonary vein.
Yeah.
And we're mapping out the S wave, D wave, and then a reversal. 1, 2, and 3. So S wave should be larger than D.
And what's S wave stand for? Systole. Yeah. So systole from beginning of QRS, end of the T wave, blood flow above the line coming towards the probe. So that's the S wave in the pulmonary vein, yeah, and then that should be bigger than this one, which is the D wave standing for diastole, obviously. And then you've got the AR, the A wave reversal, which is during just by the P wave, atrial contraction, and not surprisingly, that's meant to go away from the probe, so it's below the line. And what do we see here? So the S wave is smaller than the D wave.
We see blunting of the S wave with the reversed SD ratio is much smaller than D. So that can be from some mitral vegetation. It can be from raised left atrial pressures as well.
Nice.
So that's like.
So yeah, you call this almost S wave blunting. So yeah, raised left atrial pressure, diastolic dysfunction, anything that raises LVEDPs, and MR. Yeah, nice.
It's more sensitive in those with reduced ejection fraction. Yeah.
That's why it's a number one investigation in diastolic dysfunction.
Let's see if they. Yeah, nice. Can I just shout out to the sonographer? You see that they're changing the scale here. I'm not a big fan of variance, but they're putting variance in there. My friend Sagan taught me that from the UK. Don't put variance on. But you're looking for lower flow states here. So tone your scale down if you're looking to try and find your pulmonary veins entering into your left atrium. Because then if we come back up here and start having a look, see they've changed their scale again, looking for MR. Can't see a lot, but that's what the sonographer was trying to tell me. Let's start having a chat here. What are we have a look at that one. All right, just Ben, while we're hammering you, let me just
Yeah.
name all the parts of it. So what's this?
E.
E wave. So during diastole, early filling during diastole is coming towards the probe, so it's above the line. So that's the E wave, and then this bit is the A wave. So it's with atrial contraction.
Yeah.
So you got the early part of filling, still an active process, diastole, remember? And there's the A wave. Awesome. And then below the line here during systole, we've got blood flow away from the probe. So we're in continuous wave Doppler, so it's picking up blood flows all the way down that continuous wave Doppler profile. And so that's what's blood flows away from the probe during systole. It's got to be MR, right?
It's either going, this is where we are. We missed a section of the timing. You missed the interventricular contraction time, which is between the A and the systolic outflow. There. So the Doppler tracing that's below the baseline is either going to be going out the aortic valve, the aortic valve, or it's like vegetation. And I can't pick if I was just looking at what I'm seeing below the baseline. So it comes down to timing. So mitral regurgitation versus left ventricular outflow.
I reckon that's the MR. So I mean, I think it's just there's a tiny little sniff of a signal in there, and then it's the next one that it's almost there's another profile in there. Can everyone see that? Does that make sense to guys online? Yeah. So it's all about the timing, how to differentiate between the LVOT obstruction from the MR.
So mitral valve.
And we love asking about this in the exam for anyone doing the DDU.
MR will start first and end last. And
Yeah.
the way I remember that is because when the left ventricle starts to contract, it's got less resistance to go out to the left atrium than it does versus the aorta, because they always got high pressure. So
yeah, so I reckon that's MR starting there, and that's the LVOT obstruction starting there. It's the LVOT obstruction ending there, and I think it's probably a bit of MR in there.
Yeah.
In the exam, you're not going to be able to do this. I'm obviously doing this on our reporting software. In the exam, we just give you like a still, and you just got to do your best. But we're going to help you out a bit, right? All right, let's just we might just move on for the sake of time and just talk about interrogation of all right, let's just talk about trying to figure out where the site of the obstruction is. So again, this is really beautiful imaging. I just wanted to share it with you. You know, we're now worried about LVOT obstruction. We think we've got a signal of it on continuous wave Doppler. Now the sonographer is going on to try and interrogate it in a little bit more detail. And they're going to try and interrogate in a bit more detail. And this is what I love about looking at these formal studies of other people who know what they're doing and really beautiful studies is they're trying to tell you a story, right? So here, they're starting off by telling me, let's focus in on the LVOT. We've clearly got chaotic blood flow here as shown by all the green stuff, the variants, if you like that kind of thing, but I think you can still see it if you don't have the variants on. Now we've got a continuous wave Doppler profile that shows me that we've got quite high gradients coming through here, going almost up to 4 meters a second. Two different types of profile almost in here. There's almost look like there's one profile that then starts to get eaten out. Just like what Ben was saying, kind of tells me that I think we've got two separate things going on. There might be a little bit of MR in there, but this little sort of scalloped out profile, it's got to be some form of almost, you know, it's almost like a, what are we calling it? A stiletto? We're calling it a knife edge. Saber, you know, the saber, the knife. It's like the Crocodile Dundee's knife, right? Being sort of a chewed out edge here that happens from LVOT obstruction.
Yeah.
Emma calls it Emma calls it a mid-cap, yeah, no, you know. So yes, there's this got a scalloped out area here for LVOT obstruction. And then what the sonographer is now trying to do is they're going to try and tell us where the obstruction is, just make sure we're not missing obstruction anywhere else along that line. Because as you guys know, this view here where everything's colored in this image here is continuous wave Doppler. Continuous wave Doppler is good because you can get very high gradients, but it's bad because it can't tell you where the gradient is along the line. So what we can do then with the pulsed wave Doppler, and so here's pulsed wave Doppler, and I know it's pulsed wave because you've got two little lines in there, a gate. Here you've got the hole in the middle, it looks black in the middle. But the bad part about it is it can't tell us, it can't give us high gradients. So here it's going up to 1.5, and you can see sort of it's getting aliasing, right? So it's the pulse wave Doppler profile is coming off the top of it and wrapping around from the top. But as we move down, she's now going to start moving this profile further and further back, showing me that, I'll just do that one more time. So she starts moving that profile back as we go, and you'll see that as it comes down, the velocities start to become a little bit less, little bit less, little bit less, showing me that the highest profiles are sitting there in the LVOT, as we expected on the 2D picture, with the anterior mitral valve leaflet being sucked into the LVOT. So really beautiful imaging, showing us where the obstructive gradient is. And it's only when we start to get out of the LVOT can we actually fit the profile into our sort of maximum gradient you can get with pulse wave Doppler.
Yeah.
Yeah, hunt for the gradient. Very nice. Cool. Any questions on that? Should we move to the next case? Just going to pause the share for a moment. Can I just double check? You can't see my screen for the moment, can you?
No.
Cool, then. I just want to make sure I don't accidentally show patient details. Do you want to do? Let's do that. Yeah. Chris, Martha, how many yours? You want to try and report one for me? So just loading up the image, and I just got to blank out their patient's name. So just give me a sec. Yeah. So it's the first time we're using this system to share images. Beauty.
And does that hold
Right.
across every?
Yeah.
Yeah.
Cool. Right. Hopefully you guys can see this now again. And I've hidden their details. Beautiful. Okay. So what's the story for this guy? So this guy is 60 years old, 59 years old. And he has a history of a Bental's procedure. And I'm not entirely certain why he had the Bental's procedure, I'm afraid. And he's now presenting, he's had some syncopal episodes and a period of episode of shortness of breath, and coming in for assessment. So I think he was actually an outpatient when he was having this done, but he has had a syncopal episode, come into hospital, subsequently discharged. The TTE had suggested something, but with the background of the Bentals, was brought back in for this time. Yeah. Okay, so let's start you.
What was the underlying reason for the Bental?
I can't remember. This wasn't my case. I was just showing the echo, which I thought was awesome.
So I guess to start with, just to go through this a bit, to your fortune view, is immediately showing that both the left and the right ventricular function is not brilliant. The dominant, the left ventricle is dominantly the worst ventricle here. It also appears to be mildly dilated, well, fully mildly dilated. Biventricular size,
Nice.
and both atria appear to be quite markedly dilated, although obviously we cannot see the full extent of the left atrium. It also appears to be a foreign structure in the right ventricle perforating through the tricuspid valve. Clearly, I don't know anything more about this patient. This could be multiple things. It could be a pacing wire, it could be a right heart cath if we put that in, but I don't think he's in the critical care you see. But he's got a broadened QRS complex, so this is most likely to be a pacing.
Beauty. Just in standalone, I think we can see here maybe a bit of a lipomatous interatrial septum, where you've got sort of a clear demarcation in there, and just go. We should go hunting, obviously, looking for any kinds of PFOs.
Yeah. In terms of that left ventricle, there's clearly a little bit of dropout in the interventricular septum in the midline. That, I mean, if he's had a Bental's procedure, I'm not sure exactly what valve he's had, to what extent his valve's been replaced or repaired, but it may be that he's got a metallic valve and that's causing some dropout there. But we'll see when we come round to that. And the left ventricle, although we can't see the septum very clearly there, it appears to be globally impaired rather than any regional changes, but clearly we need to interrogate that in more detail.
I find assessing left atrial size is really hard with toe, but I think we can clearly see it's dilated here. And if it's dilated, it can tell us that, you know, we talk about that great line from Faraz, a friend of mine, who talks about the left atrium being the HbA1c of the heart. It can kind of tell you that there's a chronicity to this. Whether we've got acute or chronic, you can't tell, but there's certainly been some form of chronically raised left ventricle end diastolic pressure for this patient to give you that left atrium.
So this is some color Doppler over the mitral valve. This showing some central regurgitation. We want to interrogate that slightly more and to see where it's coming from exactly.
It's a bit jumpy. Let me just see if it settles down. If not, I might move to the next. Move to the next. See if the next slide's better.
Christian, do you know how long ago was this Bental procedure?
I think it was about 2 years ago.
Yeah.
Oh, it's a bit jumpy, isn't it?
You'll view the cross-section of the aortic valve. Though it is a bit jumpy, you can clearly see there's a huge amount of artifact deep to that valve. Of itself, appears that immediately would concern me based on that initial appearance. There appears to be quite a lot of hyperechoic material, which potentially is causing some restriction of the valve leaflets. Some restriction of the valve leaflets. I can't exactly see what's happening between the 3 and the 6 o'clock position of that valve.
Sorry,
I can't exactly see what's happening between the 3 and 6 o'clock position there.
Yeah.
But that would again be concerning about some kind of significant dehistence of the valve. And
This bit down here.
Yeah.
Yeah, fantastic.
And some you know, paravalvular. I mean, I'd like to put some color over it to see if there's significant paravalvular.
Yeah, probably that comes through better. And this is where I guess the point for me is always looking at the 2D before you make any assessment of the valve. You got to start with your 2D. If you've got significant abnormalities on the 2D, that kind of always points you toward that severe side of things for the when you start looking for the Doppler. Yeah, nice. So you know, it looks bloody horrible, doesn't it? So here we've got a Bental. So this is the abnormal structure, the graft that's been put into this person's ascending aorta. And here you've got this enormous sort of 2D defect that's coming in, that's moving around into there. See if we've got any, see if we can catch it the other way. Yeah. One of the other, just get speaker. One of the other things that we can look for, which was particularly apparent, I guess, on the transthoracic, which is why I actually ended up going for this toe, is looking at this structure here. And I know it'd be on the other side on a transthoracic, but this is significantly thickened, I think, as well here. And if we've got this sort of you know, apron, I guess the aortic cushion, I guess whatever you want to call it, but this part of the root is dilated, which suggests some form of inflammation with this 2D change. Suggests some, I think it's suggesting that we've got the Bentals, which is, if we haven't got any horrible regurgitation, but it's absolutely coming, and we're going to get some form. It's a dehisced Bental's graft. Just going to see if we can find some valvular assessment with the color Doppler. Very nice. Yeah. System's a little slow. Here we go. This is what I'm saying. Just like Emma says, infection proven otherwise, right? Talk to me through this.
All right, so this is the esophageal 3-chamber or a long axis view. Again, we can see that really concerning area of dehiscence there. Again, marked thickening in the near that region of the hypoechoic region in the aortic wall, which again is concerning. Appears to be some, yeah. It's important to say there's a lot of artifacts on this view. So deep to the valve, it's quite difficult to assess the area of dehiscence. There appears to be a kind of hyperechoic structure just proximal to within the LV outflow tract.
Yeah, you see that just sitting in there. That's absolutely right.
So again, would really make me concerned about some kind of infective cause of this, whether it's a vegetation.
Completely.
I mean, this is something that I would be immediately horrifically concerned about.
Yeah.
Probably from my perspective, consider it to be a surgical emergency and consult people very promptly.
That's absolutely right. So here we can see it's really having the echogenic structure with independent motion, even though you've got all this artifact. So it's probably a metallic, metallic valves that's sitting in there. And we're just not seeing valves opening properly because it's got some form of vector endocarditis in there with that massive 2D defect. So absolutely, surgical emergency. Interestingly enough, you'd expect a rip-roaring amount of regurg, wouldn't you? And for some reason, we're just not seeing it. But it's the 2D features in particular which are suggesting, significant abnormalities and, and as you say, infection till proven otherwise. Beautiful, isn't it? Oh, not for the patient, excuse me. Bloody awful. So if we've got
actually,
3D.
that view you can see it quite nicely. The structure.
No, this is Faraz who did this. See what he can find on this 3D.
I don't think so.
No, I think that's all right, let's move on to another case.
Sam, is there any deep gastrics on this paper?
No. Sorry, I'm just going to have to pause the screen share, excuse me. If I can let him off. What are you looking for on the deep transgastric?
Well, there's just so much. We're saying it's infection until proven otherwise, which might be reasonable in the absence of clinical history, but depending on whether it's metal or bioprosthetic in this man, it could be pannus, it could be thrombus. The motion obviously is concerning for regurg, but there's so much dropout around that graft and everything, and we did see something. I'd expect in deep transgastrics to get a better idea of what was going on. You could line it up, you could see if he had stenosis or regurg, etc. But if he had any deep transgastrics, that might be nice.
Guess no, and I always find these deep transgastrics pretty challenging sometimes at the to try and pick up things like that. I can often find I can get gradients, but I'm just having a look for you, just sorry, because I'm going to anonymize his name. We don't have any deep transgastrics, I'm afraid. As I say, I'm sorry, I didn't do this. I just saw my friend reporting on this case and asked if I could steal it for the teaching today. No, I'm sorry, we don't.
Yeah, they're the kind of, as everyone noted in the long axis, it's almost impossible to see what's going on. But with a deep transgastric, obviously, you can see that thrombus or the mass in the LVOT clearer. You can get some Doppler across it. You might even get some bit of color. But if you don't, you don't. But
yeah, I guess they're trying to get every single bit of the bite of the cherry that you can, try and do it from every single view possible. Yeah, very cool.
Hybrid.
Yeah, exactly.
Load up. Maybe let's do a. Okay. All right, I'm just going to load up the images and then just blank out a bit of the screen. It's got the patient's name on, and then I'll get this patient back up again for you. This is one of his patients. Ben, are we able to steal you again? So this lady is in hospital with a hypotensive episode, and she, I think, believes hypotensive episode is shortness of breath. What do you think?
So how old is she, roughly?
Excuse me,
50,
she is born in 52. So what's that? 52? 70.
Okay. So on my parasternal axis, it's a reasonable quality image. There's some calcification around the aortic valve. We mentioned she was hypotensive. So just off the top here, I'm worried about the extent of calcification around the aortic valve, around the mitral valve. In terms of contractile function,
Oh, yes. Yeah. So this lady, I don't know if that's what she has.
Hypotensive.
Chest pain and short of breath.
Almost kind of making it, but end stage renal failure.
Yeah, right.
So it might make more sense. And on peritoneal dialysis and came in hypotensive.
it is. I mean, her left ventricular walls are certainly thickened. They're going to be 1.5 centimeters, if not more. That can be consequent to the end-stage renal disease. I don't know why she has that. That can be hypertension. It can be an infiltrate disease, of course.
Diabetes.
And diabetes, right? So the overall contractile function of the left ventricle is probably mildly down so far. But as I said before, you might be out of the room. I am worried about the extent of calcification around her aortic and mitral valve. Can't see the aortic valve cusps opening very well, but that could be due to the calcification that's there, and it's got some dropout. I need to interrogate color and go. There's also on the anterior mitral valve leaflet, I'm not sure whether I'm just catching it at a funny angle, but it looks to be some thickening there, and again that can be disease as opposed to anything else. I can't see much movement at all around the posterior leaflet. I suspect there's going to be some mitral regurgitation and high gradients across the aortic valve, which is in sinus.
So okay. So yeah. Let's have a look through.
Put color over them all and zoom. Jumpy. So from what I can see, it looks to be high velocities around the mitral valve due to the some mitral regurgitation. In this view, I can't make a great assessment as to the severity of it. There's probably a little bit of play, but I can't see a large jet extending into the left atrium. More views. Off this view, I'd call it probably just mild. The aortic regurg there probably is. Again, there's variance going into the left ventricular outflow tract and aortic valve, suggesting that you're going to have increased gradients flowing into there. So this could be mixed mitral disease and aortic valve.
Yeah. So with sort of degenerative MAC, severe mitral annular calcification, would you be expecting to see like severe mitral stenosis like you did with the rheumatics?
No, I wouldn't expect to see severe mitral stenosis. I expect to see probably some mild to moderate, but I wouldn't be expecting severe just with ongoing calcification. Sure.
Tell me what you would use to try to now grade the severity of the mitral stenosis.
Yep, sure. So mitral stenosis needs multiple parameters to assess the severity, sort of classify it, whether it's mild, moderate, severe. So I like to see my velocities through the valve, so my gradient through the valve, not velocity, I want my mean gradients. I want to see how big my left atrium is. I want to see what my pulmonary veins are doing. I want to see what my tricuspid valve is doing and my right-sided heart pressures.
Yeah, so give me some then, like in terms of what gradients you'd be thinking about and what the caveats to that might be. With you said you think you've got mixed mitral valve.
Yeah, sure. So for flows, for any measure that's assessing flow from left atrium to left ventricle to assess the mitral valve, it will be dependent on the loading conditions of the left atrium. So if you've got, for example, mitral regurgitation, then you're going to have increased loading of the left atrium as a consequence to that, which will give you increased blood flow across the valve that may not be truly representative of the degree of stenosis. Heart rate is another one. This lady's at 101. So that will also affect your interpretation of severity, can make it look worse than what it is. Lots of numbers. So it used to be that sort of 5 and 10 for greater than 5 is moderate, greater than 10 is severe, but there is a move of drifting away from that now and using instead systolic pressures and other features, including symptoms.
Are there also concerns about the reliability of echo assessment of degenerative versus rheumatic?
Yeah, exactly, because all of the pressure half time and things like that were validated by Liv Hatley, and those initial studies were mainly on rheumatics, I think. Yeah. Generally talk about the degenerative mitral stenosis as not being generally not being severe. So what do you think of this gradient then?
So she's got a heart rate of 100, so that in itself can make the gradient look higher than what it is. Her mean gradient being 14.63 is significantly elevated.
Yeah.
Which would be, you could easily assume that represents severe mitral stenosis, but the clinical context is important in this patient.
Yeah, nice. And we've already said that we think she's got, well, did you change your mind about the degree of mitral regurg?
Stop looking at that when you start talking to me about mitral. No, look, there's still definitely mitral regurgitation there. It's, yeah, in these views I've seen so far, it's mild to moderate. I do question whether that's going to actually be quite eccentric jet, and that's going to be running around the posterior wall of the left atrium. I mean, I'm underestimating it here. There's a bit of splay by the look of it as well. If you just slow it down, I think they'd appreciate that more. I mean, there are numbers, and I've forgotten them now, but if you're going to slow it all down, interrogate for PISA and angle correct and all those things. But I'd be looking for reasons to make it worse, because I think it is worse than what I can see. So, I think I went with at least moderate on that. There was a few other images to look at. But yeah, they're all going to affect your gradient. So what else maybe can we look at as well as gradient? Did you mention what kind of pressure half time number did you have in mind? So 220 over pressure half time is what you can use to calculate your mitral valve area. The pressure half time.
Yeah. What number would you start thinking it's in the guidelines about when it's starting to become severe?
For the mitral
pressure
area,
half time.
for the pressure.
Yeah, obviously the mitral area less than 1.5, right?
Yeah,
less than 1.5 centimeters.
Yeah.
The pressure half time
Would be 150.
Yeah, and that's what's in the guidelines. So we start to go above that. And then let me just see. I don't think we've actually measured out, because actually the focus of this study is not about the mitral valve, but I don't think we've actually measured a pressure half time on there. But if you were just to eyeball that, that pressure half time isn't, it looks pretty steep, doesn't it?
Yeah.
And of course we haven't got the
I'm good now. Yeah.
Anyway, so let's focus now on the aortic valve then. So I'm just going to take you back through. So this is, we're not, I guess, end stage renal failure, severe MAC, some mixed mitral valve disease is what we've got so far.
Yep.
Probably not enough, perhaps, on its own to explain her hypotension. What do you think? Because you mentioned at the beginning you thought her LV systolic function might be just mildly down. What do you think of it?
At least mildly down. Now it's at least moderately down. Without having an old echo to compare to, I'm just going to get a touch smoother. When you had the 6 screen up, there was multiple areas that looked like to have regional wall motion abnormalities. I don't know whether they're old or new. You said chest pain, so ischemic events in a patient that's got multiple risk factors, diabetes, end-stage renal disease. Of course, depending on where she's at with her fluid status, given she's on dialysis, if she's got, she didn't have in the parasternal lungs from memory a significantly dilated right ventricular outflow tract, but if she did, then that can give you funny septum. LV systolic dysfunction. It's just a bit jumpy. I can't really call it.
I think her biplane came out to be about like 38%, but I thought was more like 30, 35-ish.
There we go. That's better. It's smoother now. Yeah, it does. So around that anterior and or anterior especially, it looks to be hypokinetic. Inferior RCA territory looks right. Septum looks moving okay.
Coming back to now, let's interrogate her aortic valve. Maybe if we start with
That's right. So even on this still, it looks heavily cusped. We try leaflet valve as well. Yeah. So there looks to be significantly restricted motion of all cusps of the aortic. There's thickening along the cusps of the valve, or along the tips of the valve. The cusps themselves don't look heavily calcified, although maybe having some dropout there because of the calcification along the chiroptake. It does look to be tri-leaflet now. I can see this going more smoothly with impaired. I think someone could try and slow it down and do a telemetry is the word, but I think that'd be tiger country in this because you can't see any edge anywhere. So I think it'd be completely useless.
It'd be very tricky though, because you get all the blooming artifact. It might be slightly better with transesophageal, but even
Maybe,
it could be quite tricky. But you could still do it, you know.
But I just wouldn't trust the numbers.
Yeah. So what do you want to see now then?
Doppler profiles.
Yeah. So what kind of
I like to see
kind of
a continuous wave, ideally as lined up as possible through that aortic valve, please, Dr. Brokaw.
Well, I might not have brought that over. The toe there.
should be? There we go. All right, so let me show you. Well,
Here we go. So I mean, if this is so just on 2D, it reinforces the findings I've already described.
you think of describe this continuous wave Doppler profile?
Certainly. So it's a continuous wave Doppler through the left ventricular outflow tract and aortic valve. Concerningly, in this patient, the peak velocity is about 4.2, which is consistent with, or can be consistent with severe aortic stenosis, which would explain her hypertension. The flow profile itself is dense. It's a dense spectral pattern. It's probably quite concave.
What do you think about the shape of it? And is that in keeping with what you're saying about that they have severe aortic stenosis?
So in severe aortic stenosis, the more severe it gets, the more triangular it will get. I guess more curved.
Yeah, more parabolic.
More parabolic.
Which is what that is.
Yeah.
It's so with mitral regurg, it becomes more triangular because you get that V cut off.
That's right.
So does it surprise you? Because I must admit, when I look at these peak velocities, seeing the degree of LV systolic dysfunction and the degree of mitral regurg, I was actually surprised that we were getting high gradients. So I was thinking, oh, this is going to be low gradient aortic stenosis, right? But it ended up being actually a gradient so high. So what might you?
Which isn't good.
No.
Which is terrible. Which is terrible.
The gradient should be higher.
Which is terrible. But it did make me look for other things that could be elevating the gradient. So what other things might you look for that we might not have seen because, you know, it's difficult imaging and all of that?
Be increasing her gradients.
Yeah.
What else would she have? Higher gradients. So flow across the valve. She's got another reason to have elevated flows across the valve.
Exactly right. So thinking about, is there aortic regurg that we've missed, and that's, or is there, you know,
a septal defect or something?
You know,
if she's at hyper
something
dynamic
that's
state,
increasing her flow.
she could be anemic.
So what are the so her DVI, what would be a severe DVI?
Under 0.25.
Nice, yeah, and hers turned out to be. And there was a couple more things. So what other things might you look for if you were, so if this lady had a gradient, say, of 2.5,
Yep.
but you were looking at that 2D valve and you're thinking that's severe.
In the setting of this left ventricular systolic
Yeah,
as well.
yeah.
Yeah.
What other things would you look at to try to help you decide whether it was true severe or pseudo severe aortic stenosis?
Yeah, right. So yeah, aortic valve area, which we can attempt to calculate velocities, gradients, and we've run through those already. We've spoken about DVI. Then the next thing is, what is the state of her left ventricle, and can we make that better to see whether we can get a more accurate representation of her flows across the valve.
Yeah.
Is that what you mean? To go down
Yeah,
that road
nice.
of saying, all right, well, we need to get her left ventricular function better. The way we do that is by stressing it.
Yep, so debutamine stress echo stuff. So what's the sort of magic stroke volume index number that we'd be looking for on here to decide whether, because remember we can get paradoxical low
Yeah,
flow,
flow,
low gradient
Yep.
as well, where you have normal EF, but because they've got a small cavity, their stroke
Exactly, they
volume
just-
index is
yeah.
less
So
than
they have a stroke length less than 0.25, 35?
35.
Yeah.
35 mils per meter squared.
Mm.
Nice, all right, yeah. So that was I guess, yeah, classic sort of renal failure patient with some severe calcific aortic stenosis. And Sam, how do I get to you?
So just do pause share, then you can go back to study list and then click on the little folder section, and then L, teaching, and then got the valves. We've done, we only had the one there.
I thought we had two.
I think you've got the valves as in regurgitation, or the mitral valve is the other one. The mitral regurg one that's to with the in, and then okay.
So would you say that the you know, the gradients across the mitral suggested severe for what that's worth, but do you think that the degenerative mitral stenosis in this case is severe mitral stenosis, or is
I
it
didn't.
mild moderate mitral stenosis, or?
Yeah, I didn't think so, Jamal, isn't it? Because I thought the actual opening of the valve didn't look severe. The fact that it's unusual to get severe mitral stenosis with degenerative disease, and the fact that she had other reasons for that gradient to be 14, in that there was at least moderate regurg and she was tachycardic. But it's someone
we are seeing more patients be referred through for severe mitral stenosis of degenerative etiology into the cardiac surgeon's realms, unfortunately. So you know, patients without aortic disease who have, you know, a high calculated gradient across their degenerative mitral valve. And so it's the question about, what do you do with these guys?
you wouldn't obviously rule it out just based on the etiology, but in general, you're more likely, you know, not to have severe, I think, with degenerative compared to rheumatic. And also her mitral valve area that was calculated, the pressure half time and everything, I think on other images that we could see didn't really fit, but it's certainly something you would keep an eye on. But I think her major problem was the severe calcific aortic stenosis. And obviously her mitral valve wasn't helping. So this is another patient that we had. The story was of biprosthetic valve query function. It's a patient that was on the ward. They weren't particularly unwell, and it was an echo to assess the prosthetic.
When they admitted under respiratory.
Yeah,
I think they were.
Red consult.
Yeah, this was a patient that I think being treated for a pneumonia.
They're on CPAP for non-invasive ventilation.
So, Chris, might you just want to comment on what you can see?
Yeah, okay.
Couple of great little bits in this case.
Yeah, so this is a parasternal long axis view with a deep field of view. Immediately, there's a few things to comment on. So the LV systolic function appears to be pretty hyperdynamic. There does also appear to be some pretty dramatic septal motion that might immediately make you kind of worried about what the right ventricle is looking like. in terms of other LV structures, we can clearly see the bioprosthetic mitral valve. There's some dropout deep to that. It looks slightly irregular, doesn't quite look exactly like you'd potentially expect a bioprosthetic valve to look. However, you can clearly get artifacts in transthoracic echo.
All right, I might just skip
Yeah.
through a little bit, Chris, just for time. What do you
LA
think?
dilatation.
Yeah, what do you think of the prosthetic mitral valve in terms of what type of valve and how it's functioning as much as you can see?
Again, it's quite difficult to see. I mean, you can see that there's two struts there. One of them is, as always is, relatively close to the LV outflow tract, so I'd want to interrogate some color Doppler over that, particularly with the hyperdynamic dynamic function. There's quite a lot of hyperechoic material in the next to that there is strut there, which I want to look at more. And on the color profile, you can see that there's intermittently quite a marked eccentric posteriorly directed jet of mitral regurgitation. Don't think we can, at the moment, I don't think it's easy to quantify that based on severity. It's hugging the wall. I don't think any of the typical parameters we'd use would be able to tell you for sure. But immediately I'm thinking that this is an eccentric jet and someone with a bioprosthetic valve, which doesn't necessarily look completely spotless. So I'd be wanting to look in more detail at the valve leaflets if possible.
And we're still at 63.
Yeah.
We're still at 63 in the jets. The color jets reaching the back of the atria, though.
Yeah.
Which immediately, I think we can say it's significant.
Significant, yeah, for sure.
It's certainly not mild. Could be severe. Could be moderate.
Yeah.
And just what's the magic word for why it's wall hugging? Because classically we talk about, the Commander effect. Yeah. So the Commander effect is the effect, obviously, for those who are studying of how the moving fluid sticks to a wall. There's some form of some form of force that keeps it to the wall, so it doesn't have all
the other thing I'd say is just that there's clearly very high velocity flow through that valve. There's again, variance is being demonstrated. It looks like there is a relatively broad jet of flow through there, but it's hyperdynamic, which may suggest that either they're kind of sick or there's significant vegetation.
Yeah, I think for me, someone has to prove to me this is not severe.
Yeah, exactly.
Like whenever you see a wall hugging big jet going back to the atrium, that's severe until proven otherwise. It's not just severe, you've got to think, why the hell is it severe, right? What's the mechanism behind this? So I might just skip for time to the toe then, and we can look through. What's that, sorry?
Yes, it's good this one.
Oh, thanks for
Just the two.
and I might just skip to a few because we are running out of the time. But what do you think of this?
It looks like a mid-esophageal fall. I don't know whether it's just because it's one cycle, but definitely one of those valve leaflets looks a little bit unusual. Like to put a bit of color over it as well. Yeah, that leaflet. Yeah, exactly. So, so there's you can see that there's a very high velocity of jet again coandering all the way around that left atrium. It's eccentric. And immediately I'll be thinking about some kind of leaflet prolapse of flail. Coandering. Yeah, so it's
Coandering.
That's awesome. Exactly.
I love it.
If we're this is a continuous wave Doppler profile through the mitral valve. The heart rate's 124, so again needs to be taken with a pinch of salt. But there's a very high gradient through there. We've mentioned 5 and 10 as our considerations, but that's that doesn't necessarily mean that it's severely stenotic, but again it supports the fact that this patient's probably a bit hyperdynamic and they've probably got some.
Yeah, it'd be hard to interrogate that gradient with that degree of regurg, right? And other things you'd be looking at. I think the most helpful thing to see whether this is pathologically obstructed is just looking at the 2D, right?
Exactly.
The problem's not with obstruction, the problem's with regurgitation, and then trying to figure out why. So just confirming that again.
Because that's one of the money shots for
Yeah.
me, right? Because it's not obstructed.
No, it's not.
It's
You
not
can see
obstructed.
clearer,
You've got a
yeah.
mechanic valve. You can
Yeah.
see that they're thin structures that appear to be opening okay. And again, all that tells us is that we've got rip roaring regurgitation.
Now these are coming up to some of the money shots now. Whether you can
You see a
see.
complete flail
Yeah.
leaf.
Yeah.
Yeah, you can see it on the 3D as well. Really
There you go,
nicely
that's it.
poking through there.
There you go.
No.
For the patient, but yeah, this
Flail leaf.
I think this is a beautiful case. Just you can't just talk about. That's we always jump, I think, straight to what the severity of the regurgitation is, but it's really all about mechanism every time, and that needed to be reported on this scan, and clearly this lady needs a surgeon to have a look at these. If he just reports severe regurg on this and don't recognize the mechanism, then that's obviously not.
Interesting, the valve
not
actually
ideal.
looks relatively well seated.
I know, I
It's-
thought that. It just not
it's more-
rocking, is it?
It's a
But this
leaflet
is
failure.
yeah. And again, until you've got infection until proven otherwise, and speaking to a surgeon.
Was this patient sick or well?
She was in heart failure in the respiratory ward. Treated for pneumonia. All right.
Guys, thank you very, very much for your time.
Thank you. Any questions on that or anything to add to this, Jamal, actually, with your cardiothoracic experience?
Yeah, exactly.
No, well, look, I mean, we talk about workflow of 3D echo for this kind of stuff. So if I was involved in this case, I mean, obviously the money's on this patient's bioprosthetic mitral valve. I presume there would have been some, I mean, that's where the money is. And so in terms of workflow, we drop the probe and my first images would be half a dozen 3D images of this mitral valve. There'd be no 4 chambers, there'd be no deep transgastrics. The first image would be a live 3D volume of the mitral valve, which would show you what you're seeing in X-plane there. We saw some of the aortic valve 3Ds previously. They still remain quite, underwhelming in my experience. But this is okay. I mean, we see a lot of stuff like this at 50 omniplane with the appendage in and stuff like that. The patient seems to still possess the appendage. But especially for the surgeons, or the surgeons are going to view this later, if the first image, or if you capture a good 3D render with the LVOT at 12 o'clock and the mitral valve underneath it, that's a view that the surgeons understand. I mean, you can walk around this at 0, 50, put color, 90, 120, et cetera, get 12 images. But a good 3D will explain everything that is happening to this valve in one loop. The patient doesn't need to be holding their breath. Patient doesn't need to be in sinus rhythm. A single image will show you what 40 other 2Ds will try and tell.
Thanks very much, Jamal. Thanks everyone for joining, and I hope you learned something.
See you next week.
See you next time. Bye.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @Nepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.